right. Welcome to the deep dive. You guys really threw us a curveball this time.
Yeah, this one's a beast.
The Standards of Care 2025.pdf on diabetes. It's massive. Our mission today, we're going to navigate this huge set of guidelines.
Straight from the experts, MDs, PhDs, the whole ADA scientific team, and pull out the most important updates. The actionable stuff for anyone who wants to understand the latest in diabetes care without getting lost in the weeds.
Exactly. Let's dive right in. The guidelines open with a really big emphasis on something called person-centered care and also these social determinants of health. What's that all about?
Well, the first thing that jumps out is this fundamental shift in how they're framing diabetes management. It's going way beyond just those blood glucose numbers. It's really about understanding you, the individual, within the bigger picture of your life.
So less like a textbook protocol, more like tailoring a plan to your actual life.
Exactly. They define person-centered care as looking at your comorbidities, any other health conditions you might have, and your preferences, your needs, your values, basically everything, before making any clinical decisions.
So it's all about making the plan fit you, not the other way around.
Right. And tied directly to that is this huge focus on the social determinants of health.
I feel like that's so important, but it's often overlooked.
It is. If we zoom out for a second, these guidelines are saying, hey, there are all these factors outside of your control that have a huge impact on how you manage your diabetes. Things like, what's your socioeconomic status? Do you have access to healthy, affordable food? Is your neighborhood even safe enough for exercise?
Right, so it's not just about willpower and making the right choices about diet and exercise. Sometimes there are real barriers in the way.
Exactly. And to truly improve well-being for everyone with diabetes and get rid of those disparities we see, especially in racial and ethnic minorities, people in underserved areas, people facing financial hardship, we've got to address these underlying social determinants.
So it becomes less about blaming individuals for not complying and more about understanding their whole situation.
Precisely. What this means for you, the listener, is that your doctor shouldn't just be focused on your A1C. They should be asking about things like, do you have access to healthy food? Can you safely exercise in your neighborhood? All of that needs to be part of creating your diabetes management plan.
That's a huge shift in perspective. Okay, let's move on. The guidelines then jump into diabetes self-management, education, and support. DSMES, right? And, of course, the role of technology, which is just exploding.
Yeah, DSMES is still super important, a cornerstone, really. And they're emphasizing that it's not just a one-time thing at diagnosis. It should happen annually and during any major life changes or healthcare transitions.
So it's ongoing support and education to help people manage their own diabetes effectively.
Right. And what's interesting is that DSMS is becoming much more integrated. It's not just about the clinical facts anymore. It also incorporates behavioral strategies, things like goal setting, problem solving, coping mechanisms, and crucially, it addresses mental health and well-being.
So it's a really holistic approach to empowering people to live well with diabetes. And of course, technology is a big part of that these days.
Huge. Online and mobile DSMES platforms are becoming more and more common, which is great for accessibility, but the guidelines also acknowledge the digital divide. Not everyone has equal access to tech and the internet. That's something we've got to address to make sure everyone benefits.
Definitely. Speaking of technology, CGMs, continuous glucose monitors, and those connected blood glucose meters are really changing the game.
Oh, absolutely. The beauty of these tools is that they allow for real-time, two-way communication between you and your healthcare team. It's not just about passively collecting data anymore. It's about using that data to have informed discussions, make adjustments to your medication, tweak your lifestyle, make it all more personalized and proactive.
It's amazing how much more data we have now to work with.
And the guidelines even touch on some really cool stuff like virtual reality environments for DSMs. Early research suggests VR might be really effective for things like weight loss.
VR for diabetes education. That sounds futuristic.
It does, but it's already happening. But the main takeaway about tech is this. We need wider adoption, better insurance coverage, and better reimbursement for these amazing tools. If we want everyone to benefit, we have to make them accessible and affordable.
Absolutely. Now let's switch gears a bit and talk about how diabetes is actually diagnosed. The guidelines have very specific recommendations for screening and diagnosis.
Yeah, this section can get pretty dense, so let's break it down. For prediabetes and type 2 diabetes, they recommend screening asymptomatic adults. So basically people who aren't showing any symptoms yet. And you can use either established risk factors, they list those in the guidelines, or one of those validated risk calculators.
So if I'm not experiencing any symptoms, how do I know if I should be screened?
Well, one important thing to remember is that if you're overweight or have obesity and have at least one other risk factor, you should be screened regardless of your age. For everyone else, they recommend starting screening at age 35.
Got it. And what if my initial screening results are normal? Should I just stop worrying about it?
Not necessarily. If your initial results are normal, they recommend getting rescreened at least every 3 years. But you should be screened more often if you develop any symptoms that might suggest diabetes, or if your risk factors change significantly, like if you gain a lot of weight or if you have a family member who's recently been diagnosed with diabetes.
Okay, so it's not a one and done kind of thing.
Hmm.
Makes sense. And what are the actual tests they use for screening?
There are three main tests they mention: the fasting plasma glucose, FPG test, the 2-hour plasma glucose test during an oral glucose tolerance test, OGTT, and the A1C test. All of those are considered valid screening tools.
All right, that covers prediabetes and type 2. What about type 1? Is the screening process similar?
It's actually quite different. Right now, genetic screening for type 1 is mostly used in research. It helps identify people who might have a higher genetic risk based on their HLA genes.
HLA genes.
Yeah, those play a big role in your immune system. And certain variations of them are more common in people who develop type 1. The guidelines define different stages of type 1 based on the presence of certain autoantibodies in your blood and your blood glucose levels. Stage 1 is when you have 2 or more of those autoantibodies, which means your immune system is attacking those insulin-producing cells, but your blood glucose is still normal. At this stage, you have about a 44% chance of developing full-blown type 1 within the next 5 years. Then, stage 2 is when you still have those autoantibodies, plus your blood glucose starts to rise. It's what they call dysglycemia, but it hasn't hit the threshold for a diabetes diagnosis yet. At this stage, the risk is much higher. You're looking at a 60% chance of developing type 1 within 2 years and a 75% chance within 5 years.
So it's a progressive autoimmune process. They can catch it before it becomes full-blown diabetes. I also noticed the guidelines mentioned something called monogenic diabetes syndromes. Is that like a different category altogether?
Yeah, monogenic diabetes is much rarer. It's caused by a mutation in a single gene. There are two main types they highlight: MOBY, which stands for maturity onset diabetes of the young, and neonatal diabetes, which is diagnosed in babies under 6 months old. Genetic testing is super important for these cases because monogenic diabetes can easily be misdiagnosed as type 1 or type 2, which could lead to the long treatment.
So when should a doctor suspect monogenic diabetes?
Well, they recommend genetic testing for any baby diagnosed with diabetes within those first 6 months of life. That would be neonatal diabetes. For MODY, they suggest considering genetic testing in kids and young adults whose diabetes doesn't fit the typical type 1 or type 2 patterns and who have a strong family history of diabetes that runs down the generations. That suggests an autosomal dominant inheritance pattern. Oh, and one more thing. If someone has those autoantibodies that are typical of type 1, it's much less likely they have a monogenic form of diabetes. So genetic testing might not be necessary in those cases. They even give examples of specific types of neonatal diabetes, like there's one caused by a mutation in the KCNJ11 gene, which affects potassium channels that are crucial for insulin secretion. And sometimes that type can actually respond to a class of drugs called sulfonylureas.
Wow, the level of detail is impressive. It really shows how important it is to get the diagnosis right so you can get the right treatment. What about gestational diabetes, the kind that develops during pregnancy?
For gestational diabetes mellitus, they recommend risk-based screening after puberty in women who have certain risk factors for GDM. The details of when and how to screen are pretty extensive and usually handled by OBGYNs during prenatal care.
Okay, makes sense. We've talked a lot about how diabetes is diagnosed. Now let's get to the meat of it, managing it. And that brings us to glycemic goals and the ever-present concern of hypoglycemia, low blood sugar.
This is really the heart of living with and managing diabetes, right? The guidelines talk about this ADG study. It stands for A1C-derived average glucose. Basically, it helped connect the dots between your A1C results, which reflect your average blood glucose over the past 2 to 3 months, and the daily glucose values you see on your meter or CGM.
So it helps make sense of that A1C number.
Exactly. Table 6.1 in the guidelines actually gives you those approximate equivalent values. And nowadays, when you get your A1C result, it often includes an estimated average glucose, or EAG, which can make that A1C number feel a bit more tangible and relatable to your day-to-day life.
Yeah, that definitely helps.
They also highlight findings from some of the classic diabetes studies, DCCT, UKPDS, that showed a curvilinear relationship between A1C and the risk of complications.
I'm not sure I follow.
Basically, what it means is that the biggest reduction in risk comes from lowering a very high A1C levels to a more moderate range. So going from, say, 10% to 7% makes a huge difference. But going from 7% to 6%, while it can still be beneficial, the impact on risk reduction is smaller. So the takeaway is if someone's A1C is consistently between 6% and 7%, and they're not at high risk for hypoglycemia and have a long life expectancy, there's no need to be super aggressive in trying to lower it further.
And thankfully, we now have better meds and tools that help people manage their blood sugar without driving up the risk of hypoglycemia.
Totally. Newer drug classes like GLP-1 receptor agonists and SGLT2 inhibitors, along with CGM, can really make a difference there. But on the flip side, the guidelines stress how crucial it is to assess someone's hypoglycemia history at every single visit. Ask about frequency, severity, triggers, symptoms, the whole nine yards.
So don't just brush past it. It's an important conversation to have.
Absolutely. It's also worth encouraging people to really pay attention to how they feel when their glucose is high or low. Sometimes people think they're having a low blood sugar episode and treat it without actually checking their glucose or vice versa.
Good point. Okay, now let's get into the nitty-gritty of the treatment of the pharmacologic approaches. This is an area that's always changing, right?
For sure. The guidelines give a general overview of how much different drug classes typically lower A1C, like insulin and some GLP-1 receptor agonists, especially the higher doses of semaglutide and tirzepatide, tend to have the biggest impact. DPP-4 inhibitors, on the other hand, have a more modest effect. They also mention the GRADE trial, which compared different meds added to metformin.
What were the big takeaways from that trial?
So after 5 years, they found that all the drugs studied did lower A1C, but insulin glargine and liraglutide were slightly better at keeping it below 7% compared to sitagliptin and glimepiride. Interestingly, severe hypoglycemia was more common in the insulin glargine and glimepiride groups. But the main message when it comes to choosing meds is this: shared decision-making. The best drug isn't just the one that lowers blood sugar the most. You have to consider side effects, hypoglycemia risk, cost, and what the person actually prefers.
Makes sense. It's about finding the best fit for each individual.
Right. And they give guidance on when to start dual therapy that's using two different drug classes, or when to consider more potent agents. Usually that's when someone's A1C is 1.5% or more above their target. They also talk about when to start insulin, which is usually in cases of really high blood sugar, or if there are signs of ketones in the urine, which could indicate DKA.
And we're seeing more and more drugs that have benefits beyond just blood sugar control, aren't we?
Oh, yeah. The guidelines really emphasize those added benefits of GLP-1 receptor agonists and tirzepatide. They can lower A1C, reduce hypoglycemia risk, help people lose weight, and even have positive effects on the heart, kidneys, and liver. SGLT2 inhibitors also get a shout out for their benefits in people with heart disease, heart failure, or chronic kidney disease, what they call cardiorenal metabolic disease.
And weight management is a big deal for many people with type 2. How do the guidelines address that?
They specifically say doctors should think about weight when choosing meds for people with type 2 and obesity. Drugs that help with weight loss should generally be prioritized, while meds like insulin, sulfonylureas, and thiazolidinediones, which can sometimes cause weight gain, should be used more carefully.
Insulin therapy can be tricky. What specific advice do they give about starting and adjusting insulin?
For basal insulin, which is the long-acting kind, they suggest starting doses based on body weight and how high the blood sugar is. But they also warn about over-basalization, which means giving too much basal insulin. That can mask problems with mealtime insulin doses not being high enough. Signs of over-basalization include big swings in glucose from bedtime to morning or between meals, hypoglycemia at night, and just high glucose variability overall. If you see those signs, it might be time to reevaluate the basal dose. They also talk about prandial insulin, which is the fast-acting kind you take before meals. A general rule of thumb is to start with about 1 unit of rapid-acting insulin for every 10 to 15 grams of carbs in a meal.
And we can't forget about the medication shortages happening these days. Do the guidelines address that?
They do. They give specific advice on what to do if a drug becomes unavailable. They also talk about important considerations for women of childbearing age and ways to reduce the risk of DKA in people taking SGLT2 inhibitors who might be at higher risk, like those on keto diets. And they briefly cover treatment for diabetes caused by other conditions like chemo, cystic fibrosis, organ transplants, and those monogenic types we talked about earlier.
Wow, it sounds like they really tried to cover all the bases.
Okay.
Let's move on to diabetes technology, which we touched on earlier with DSMES.
Yeah, they have a whole section dedicated to technology. They stress that anyone involved in diabetes care needs to be up to date on how to use these new tools. And they strongly advocate for equal access to CGM, insulin pumps, and those automated insulin delivery systems for everyone, regardless of age or A1C. They even suggest considering starting these technologies early on, maybe even at diagnosis, depending on the person's needs and preferences.
Starting those technologies early on, that seems like a good idea if it leads to better outcomes.
It makes sense, right? They also talk about the importance of using those standardized reports from devices, like the ambulatory glucose profile and weekly summaries. Those can give you a really good picture of glucose trends and help guide treatment decisions. And there's been big progress with CGM use during pregnancy. Several real-time CGMs are now approved for use throughout pregnancy.
That's great news.
It is. Studies have shown that real-time CGM in pregnant women with type 1 can improve A1C, increase time in range, and reduce the risk of problems for the baby. They also talk about the benefits of insulin pumps for kids with type 1. They can lower the risk of DKA and other complications and improve quality of life. And lastly, they mention half-unit insulin pens, which can make it easier to fine-tune insulin doses, especially for kids or people who are really sensitive to insulin.
It's amazing how much technology is changing diabetes care. Okay, let's switch gears again and talk about healthy behaviors and overall well-being.
This section really emphasizes that diabetes care isn't just about meds and technology, it's about you, the individual, and your behaviors. They talk about the need for personalized meal plans, and they make it clear there's no one-size-fits-all approach to macros. How much of your calories should come from carbs, protein, and fat. It all depends on your eating habits, preferences, culture, and metabolic goals.
So what are some of the specific dietary recommendations?
They say to limit sodium to less than 2,300 milligrams per day, mostly by cutting back on processed foods, and choose water over sugary drinks, obviously. They even say that using non-nutritive sweeteners in moderation and for the short term can be helpful for some people who are trying to reduce their calorie intake.
And what about religious fasting?
They recommend using a specific risk assessment tool to figure out if fasting is safe for each individual. And they stress the importance of adjusting the treatment plan ahead of time to minimize risks like hypoglycemia, dehydration, high blood sugar, or even DKA.
Mental health is so important too. Do they talk about that?
Big time. They recommend regular screening for things like diabetes, distress, feeling overwhelmed by managing diabetes, depression, and disordered eating. They say to use standardized screening tools, and the ADA even has a mental health toolkit with helpful questionnaires and resources.
Disordered eating is a big problem in the diabetes community, and it can be hard to catch.
Absolutely. And they specifically recommend screening for disordered eating behaviors, including things like intentionally skipping insulin doses to lose weight. If someone shows signs of disordered eating, they should be referred to a specialist.
I noticed they also mentioned sleep problems and disability.
Yeah, they acknowledge that sleep disturbances are common in people with diabetes, things like sleep apnea, insomnia, restless legs, and they talk about how shift work can make things worse. They recommend looking at lifestyle factors to see if there are any modifiable risk factors for poor sleep. And they also stress the importance of assessing for disability at every visit and referring people to specialists if needed. They point out that people with diabetes are at higher risk for disabilities that affect mobility and daily living activities.
Okay, let's talk about prevention. What do they say about preventing or delaying diabetes and its complications?
For people with prediabetes, they strongly recommend lifestyle interventions that focus on losing weight, being more active, and getting nutrition counseling. They specifically mention the Diabetes Prevention Program, DPP, and its online and virtual versions, as well as the Medicare DPP. Interestingly, they note that these programs sometimes have lower retention rates among younger adults and minorities, which suggests we need more diverse approaches to keep people engaged. They also point out the effectiveness of community health workers in delivering DPP-like programs. And, of course, they emphasize the role of registered dietitians in managing prediabetes. They also talk about using meds to prevent diabetes, with metformin being the main recommendation. It's safe, and it's been shown to be effective in certain groups like people with a BMI over 35, younger folks, and those with a history of gestational diabetes.
That's a lot of ground to cover. And the guidelines also have specific sections for older adults and children and adolescents with diabetes, right?
Yes, they do. For older adults, the big idea is to individualize glycemic goals based on their overall health status. They categorize health as healthy, intermediate complex, or very complex poor, and they give different A1C and time and range targets for each category, with a big focus on avoiding lows, especially in those with more health issues. They also stress that screening for complications and treating cardiovascular risk factors should be tailored to each person's life expectancy and quality of life. For older adults with type 1, they emphasize that insulin is life-saving and discuss potential challenges with technology, the importance of caregivers, and issues that come up in long-term care facilities. They even recommend diabetes education for staff in those facilities, and they introduce the 4Ms framework, mentation, medications, mobility, and matters most, as a guide for person-centered care in older adults.
And what about kids and teens with diabetes? Is their management much different from adults?
There are some key differences. The guidelines talk about both type 1 and type 2 in youth, and they note that type 2 in kids tends to progress faster and lead to complications earlier than in adults. They also highlight how type 2 disproportionately affects marginalized communities and emphasize the importance of family involvement and culturally appropriate approaches. Because of the higher risk of complications, they recommend a lower A1C goal for kids with type 2, usually below 6.5%. They outline management strategies for new onset type 2 in overweight and obese kids, including lifestyle changes, metformin, sometimes GLP-1 receptor agonists, and insulin if needed. They also bring up the risk of something called cannabis hyperemesis syndrome, which can cause severe nausea and vomiting and lead to DKA in kids with type 1 who use cannabis. They strongly advise against cannabis use in this population. Lastly, they really emphasize the importance of screening for mental health issues and family factors, both at diagnosis and during follow-up visits, and making referrals to mental health professionals as needed. And that includes screening for things like food insecurity, housing instability, and financial barriers to care.
Diabetes in pregnancy is a whole other ballgame, too. What are the key recommendations there?
They really stress the importance of preconception care for women with a history of gestational diabetes or pre-existing diabetes. The goal is to get blood sugar under control before pregnancy to prevent birth defects. And they give specific targets for blood sugar during pregnancy that are often tighter than for non-pregnant adults. They also highlight the role of CGM in helping women reach those targets. And of course, nutrition therapy and working with a registered dietitian are essential. They recommend low-dose aspirin starting at 12 weeks of pregnancy to prevent preeclampsia in women with type 1 or type 2. And they advise continued screening for diabetes every 1 to 3 years after pregnancy for women who had gestational diabetes because their risk of developing type 2 is much higher.
And the guidelines even cover diabetes care in the hospital, right?
Yep. They talk about general blood sugar targets for hospitalized patients, which are usually between 140 and 180 for most people who aren't critically ill. They discuss how to manage insulin when someone's on tube feeding or IV nutrition, and they explain the typical blood sugar patterns you see with steroid treatment. They highlight the usefulness of point-of-care glucose meters and the growing use of CGM in hospitals. And lastly, they touch on the risk factors for hypoglycemia in the hospital and ways to predict it.
And I think the very last section briefly mentions advocacy efforts related to diabetes.
Yeah, they give a quick overview of the ADA's advocacy work on things like employment rights for people with diabetes, safe driving rules, access to affordable insulin, and proper care for students with diabetes in schools.
Wow, we really did cover a ton of ground today. I feel like my brain is full.
I know, right? These guidelines are massive.
So, to sum it all up, what would you say is the biggest takeaway from these 2025 standards of care?
I think the overarching message is that diabetes care needs to be truly personalized and comprehensive. It's not just about numbers, it's about the whole person. It's about using the latest meds and technology, but also understanding each person's individual needs, preferences, and life circumstances. And it's about addressing those social and behavioral factors that play such a huge role in health and well-being.
It's about moving beyond just focusing on blood sugar and taking a more holistic view of the individual.
Exactly.
And we hope this deep dive has given you a good overview of the most important updates and recommendations from these guidelines.
We did our best to cut through the clutter.
Absolutely.
But it does make you think, with all these advancements in diabetes care and technology, how can people advocate for themselves to get access to the best possible care? How can we make sure everyone gets that truly person-centered approach? It's a question worth pondering, maybe even exploring further with the resources the ADA offers.
Great point. Lots to think about.
Yeah.
Until next time.
See.